Welcome to the THOR Table of Knowledge podcast, where we dive deep into the groundbreaking world of trauma care, hemostasis, and oxygenation research. A special thank you to our sponsor, Velico, for their support. Velico is revolutionizing trauma care with their innovative frontline ODP spray-dried plasma system, with the goal of empowering blood centers worldwide to produce dried plasma for transfusions.
We're going to kick this off with a discussion of how the THOR network got started and how it's had a revolutionary impact on trauma and resuscitation science and care of patients. So Phil, why don't you talk to us about the very beginning? How did this all get started?
Sure. Well, interestingly, it started with an email that I got from Geir Strandenes back in 2010. Geir then was responsible for the training for Norwegian Navy SEAL medics, and he was interested in implementing whole blood for his medics. So he emailed me saying, I've read some of your literature. I would love for you to help us implement whole blood here for our Navy medics in Norway. And would you also kind of chair my scientific steering committee that I'm developing? So of course, when someone like that emails you and asks for help, I was basically getting an email from a Viking, asking who turns down a Viking, right?
Right.
So I was like, of course. And honestly, everything that Geir went through in his email was research I had wanted to get done in the lab, but I just wasn't able to because of all the other work I was getting done. So it was almost kind of like a gift from the gods, right? And we started to have a few conversations, and then I was invited to speak at a meeting in Innsbruck, Austria. I said, Geir, I'm going to be in Innsbruck. Just hop on down, let's meet in person. Let's talk about your implementing whole blood and your scientific program. So after the meeting, we went out to an Irish bar, Limerick Bills, in Innsbruck, and we sat at the back left table. And after a few Guinnesses, we said, well, in addition to developing your program there in Bergen for your Navy SEALs, I said, let's broaden the scope. Let's go big. Why don't we have a meeting every year that's invite only? We'll get the world's leadership together in both trauma and transfusion medicine. And if we bring everybody together, we'll be able to facilitate change. Because I think we both recognized at that point, everybody was still an army of one. There were many people in 2010 still supportive of improving hemostatic resuscitation principles, mainly focusing on whole blood, but other aspects, dried plasma, et cetera. But whole blood was was the main interest. And we felt that we could get the world's leadership together, there's strength in numbers, right? And we could facilitate change faster. And that's how it all started. We had our first meeting in 2010. Our first meeting in 2011 in downtown Bergen. And then the next year we moved it to the Solstrand Spa, which was the idea of Geir's wife, Gru, who said, this is a beautiful place. You're better off having this meeting here, which really did help, I think, the network get started, because the Solstrand Spa it's an amazing, beautiful place on the mouth of the fjord. There's glaciers in the background. It's one of the most picturesque places in the world. And you could have 180 people stay there. There's a conference room there that could hold 180 people, and it just seemed perfect for the network. And I really think without the Solstrand Spa as a location, the network may not have been as successful as it was early on. It definitely has been a big piece of the network.
So clearly, the very beginning of THOR was bound up in this idea of implementing whole blood. Now, certainly for those of people who have followed the changes in trauma and transfusion medicine, the rebirth of whole blood has been one of the biggest changes in the management of bleeding patients in decades. We can look back to really the Vietnam War era, where people started using saline or other products, which they had tried in previous conflicts going back to World War I even, as a simple but not very effective means of resuscitating patients who are bleeding. And you mentioned the term hemostatic resuscitation. Your own military experience informed your thinking on how to resuscitate patients and got Gare's interest, as you mentioned, to help found this network. So why don't you tell us a little bit about this, about your own experience in the military and this idea of where hemostatic resuscitation comes from as opposed to giving people salt water, and how this has really catalyzed change driven by the THOR network, and then launched THOR on its current mission.
Sure. So just for clarity for the audience, hemostatic resuscitation as a term just defines the use of a blood-based resuscitation, right, versus the classic approach starting with crystalloids and only going to blood products if laboratory values indicated its use, which delays its use.
Right, basically just causing dilution with the crystalloids as opposed to giving back the material that can support blood clotting and hemostasis, as you said, right?
Right, yes. But my experience with whole blood actually didn't start in the military. My experience with whole blood started during my fellowship. As a pediatric critical care physician in my fellowship in the Children's Hospital of Philadelphia, we used whole blood every day for children with post-cardiac surgery with significant bleeding. We also use it routinely for craniofacial surgeries that had significant bleeding. So during my fellowship, I was trained to use whole blood whenever a child had significant bleeding. And then after my fellowship, 6 months later, I deployed to Iraq with the 1st Cavalry Division. And as I started to work at the 31st Cache and started to work with the team to resuscitate casualties, I naturally said, "Where's the whole blood?" And everybody looked at me like I was crazy. So, well, what do you mean whole blood? We don't have that here. No one has used that for decades. And I said, well, actually, I've been using it every day in Philadelphia. We should use it. Trust me, we would rather use that than individual components. So with support from leadership at the Cache and their knowledge of the use of whole blood historically, to include the Battle of Mogadishu, where John Holcomb and others utilized whole blood too in the early 90s. There was that historical knowledge
but basically only as a rescue therapy when everything else failed or other
Correct.
blood products weren't available.
And
right?
that's how we started to use it at the 31st Cache, but with the what we call the other EBM, experience-based medicine. Our experience using it late in the resuscitation, and then some patients responding. Then we moved it up to, halfway through the surgery before they started to get sick. And then we started to collect it before casualties even showed up. And that 1 year of using whole blood led many of us there at the 31st Cache to realize we were doing something very special and that we had to record it. As a result,
Data.
Your mentor, Jeremy Perkins, we asked Jeremy to stop taking clinical care and go collect data on close to 4,000 casualties that came through the Cache that year. And that was the beginning of all the 31st Cache publications that not published not only on whole blood, but also factor 7A, increased ratios of plasma and platelets to red cells,
Early use of platelets.
tourniquet use, how much blood do you need for mass cows, et cetera. So it was that experience. But that experience that led us to ask the question, why? Mm-hmm. Why? What is it about whole blood that may make it better than individual components? And it's a few different things. First thing that I recognized was that whole blood was fresh, right? You didn't have the storage lesion associated with it for red cells, plasma, and platelets. That made us look into how old the red cells were that we were giving in Baghdad at that time. And the most frequent storage age, or the mode of storage age of the red cells at that point, was 42 days. The day of expiration for red cells was when we were using it the most. So it was incredibly old relative to what was normally used. The median age of red cells back then was 33 days of age. Again, very old compared to what's normally used. So when you use fresh whole blood, your red cells are fresh, your platelets are fresh, and the plasma hasn't been stored for a while, which can lead to a reduction in hemostatic potential. But other benefits of whole blood are that it's a more potent product relative to giving components in a 1-to-1-to-1 unit ratio. When you use whole blood, it's only in the 53, 57 mLs of anticoagulant in that one blood bag. If you split that whole blood into components, you've tripled the citrate and anticoagulants that are now transfused to the casualty.
So it's more dilute.
More dilute, which can lead to, delusional coagulopathy, and that citrate is also a direct anticoagulant too. So whole blood is a more potent product. Relative to putting back blood together 1-to-1-to-1, whole blood has a much higher hemoglobin, much higher platelet count, and much more coagulation factors. In addition to that, it's safer, right? With a cold stored, with fresh whole blood, it's safer because if you use only group O whole blood, and things have changed over time, but when you use group O whole blood, right, there's almost zero risk of a fatal hemolytic reaction because you're using a group O red cell within that group O product. When you use individual components, it's very standard to, once you do your ABO testing, to then switch to ABO compatible products. That can lead to human error and lead to fatal hemolytic reactions. Actually, we did have a child die that year on us in Baghdad who, when we switched to components, got an incompatible red cell and died from a fatal hemolytic reaction. So it's safer. When people use cold stored whole blood, it's safer because now the whole blood is stored cold. There's very little risk of bacterial contamination in that product. Whereas when you use components, where the platelets are normally at room temperature, there's increased risk there. About 1 in 800, 1 in 500 units can have bacterial contamination. So whole blood is actually safer in addition to being more efficient. And then you have the logistic benefits, right? When you're only transfusing one product versus 3, it's much easier for the blood bank to allocate it to the bedside so it gets out faster and it gets given faster to the patient. And we all know time is money. There's now very good data supporting that the faster you transfuse a patient who's bleeding to death, the better the outcomes. It seems obvious, but the magnitude of that effect is quite dramatic.
So that's the key thing. So in addition to all of these, logistical and theoretical advantages, there was the data. At the 31st Combat Support Hospital, where you and Jeremy and others worked, you gathered an extensive amount of data that you were able to compare the outcome, that allowed you to compare the outcomes of patients transfused whole blood versus component therapy, including components that contained platelets. Talk a little bit about that clinical data.
From the database that I just talked about, where Jeremy pulled over 500 variables per casualty, and again over 4,000. From that robust database, we analyzed casualties that got whole blood as part of their resuscitation compared to those that received only components. And when we published that manuscript in 2009, it started to help increase the implementation of at that point, one fresh whole blood. In that retrospective study of about 300 casualties, we showed that if for those casualties that received 30% of their resuscitation volume as whole blood, there was a significant improvement in survival. There was a 13% absolute reduction in 28 30-day mortality for those casualties that received whole blood. And that was, I think, the data that just reignited interest kind of worldwide in whole blood, having us rethink this practice change that occurred with no data, right? When we changed from whole blood to components in the 70s and 80s, it was based upon convenience and the concept that for an oncology patient, it was better to have an individual red cell unit, individual platelet plasma unit. For patients with severe bleeding, the concept was, that they just need red cells because oxygen delivery is all that they need. The concept of hemostatic resuscitation, the hemostatic aspect of resuscitation, was undervalued and kind of dismissed and de-emphasized to the point where the practice, even ATLS for decades, focused on red cells primarily, and then only giving platelets and plasma if a lab test indicated it was needed, which also took a half hour, 60 minutes to get back. So we kind of went down this pathway where we were using the wrong products, component therapy, for patients with severe bleeding. And that 2009 data reminded everybody about what we used to do. And it made people rethink the why we give it components. And that is what I think really helped ignite the interest and get people around the world saying, no, we got to go back. We got to go back to doing what we used to do from that one manuscript and then others.
And so the timing of that was perfect, right? Because that was 2009. You and Gare met in 2010 and launched the meeting in 2011. And of course, by the way, Jennifer Gurney and colleagues at the Joint Trauma System have since looked at the entire data set from the wars in Afghanistan and Iraq from 2001 essentially to 2023, I believe. And not only confirmed your initial observations on the benefit associated with whole blood transfusion, but shown in a remarkable set of subset analyses that the benefit of transfusing whole blood holds across multiple different analyses and patient populations. Yeah. So it's super exciting. I mean, and the civilian data that's coming out supports this as well. So this was really the catalyst that drove the beginning of THOR's mission.
Yes, it was the centerpiece,
right,
so to speak. But then quickly, the THOR network started to incorporate other aspects of hemostatic resuscitation, antifibrinolytics, dried plasma, cold stored platelets as other adjuncts, other tools in the toolbox, right, that we all recognized we needed to facilitate improved resuscitation. Eventually, calcium, came on the scene.
Really, the whole panoply of interventions in the initial management of the traumatized or at least shocked patient from hemorrhage.
Right, agreed. Yes, but whole blood was the initial crown jewel, so to speak, within the THOR network, but we've since expanded and continued to facilitate getting research done in all of these areas, as well as developing training and education programs too, as well as participating in large advocacy programs, right? Such as improve, at least in the U.S., allowing for reimbursement for the use of blood products in the pre-hospital phase of resuscitation, which has been a major barrier for implementation in the United States for pre-hospital blood, which is where the money is, so to speak. But if you're going to improve outcomes for patients with traumatic hemorrhagic shock or any etiology of hemorrhagic shock, pre-hospital GI bleeding, postpartum hemorrhage, you must start the resuscitation pre-hospital.
That expansion of the THOR area of influence and interest was born out of success, right? Because the network has had some notable successes in advocating for research, education, training, and policy change, actually, in the implementation of whole blood. Now, just to take us back to sort of the historical aspect here, we had that first meeting in 2011, which was a relatively small meeting and very focused on whole blood. And that was in downtown Bergen, Norway. Beautiful city, by the way. Tell us a little bit about how it evolved subsequently and why the structure of the meeting and the network has facilitated success in advancing patient care.
In 2011, our first meeting was in downtown Bergen. It was only a half-day meeting. But after the success of that meeting, and then actually going to dinner at the Solstrom Spa that night, we had the idea, and actually it was Gare's wife, Gru, who said to the two of us during dinner, moving forward, the network should have its meeting at the Solstrom Spa, which we both immediately thought was brilliant because the Solstrom Spa is in an isolated place about a half hour south of Bergen. It's a beautiful facility where we could house up to about 180 people and have the conference in the hotel room. And what's really unique about that location is that it's quite remote. There's not much else you can do outside of that venue, which for us was important because if we were going to bring the world's leadership together, we wanted them to stay together. All the way from in the morning, when we did our deep sea swim in the fjord, through breakfast, lunch, dinner, and then as well as meeting in the bar afterwards. And we truly believe a major part of the success of the THOR network and our productivity has been the location at the Soul Spring Spa and the fact that it's remote. And it's also a place that many people want to come to too. So that's how the THOR network eventually led to the Soul Spring being its kind of home base. But since then, we've because there's been such a demand for us to hold courses, we now have THOR on the road meetings, and we've been to many other countries in the past. Zermatt, Switzerland, Brazil, Israel, Australia last year. This year we'll be going to Spain too, and that has really helped us spread the message as well. In addition, the influence of the THOR network goes well beyond the yearly meeting that we have. We publish a supplement every year, mainly from the presentations at the meeting, and that supplement often will have 20, 25 articles in it. It's been our main way of disseminating information in addition to the meeting itself. And then we've also started to publish position papers as well too, to help guide the industry and the different disciplines on what is the optimal approach to hemostatic resuscitation for patients with severe bleeding. Part of the success of THOR too has been its multidisciplinary network. From the very beginning, it was our intention to be very balanced. Half military, half civilian. Half kind of European, Asian-based, half North American as well. We always wanted to have a wide breadth of different disciplines. Medics were always very important for us to include in the leadership of the network as well as presenting at the meeting. As Gare likes to call them, they are the doers. They're the ones on the front lines providing the hemostatic resuscitation or the remote damage control resuscitation. So they have always been very integral to the network. But in addition to medics, right, all different types of providers, whether it be emergency medicine, surgery, anesthesia, pediatrics, even hematologists we have in the network as well too.
Even hematologists, I like to hear that. So you mentioned the medics, and I think it's important here to remind the audience that there's another component to the conference that we affectionately call the pre-conference course. So this has really been Gare's baby, if you will, where he has brought together mostly military, but some civilian medics from around the world, mostly NATO countries, but or NATO sort of affiliates, for a 3-day training session at another remote location on the coast of Norway, where really there's a mix of didactic activities plus practical training and a competition actually between teams that fosters both the learning of new techniques, the sharing of techniques, and the identification of challenges for implementation in the pre-hospital setting. That's been a tremendous success, and we've actually brought those medics out of the pre-hospital course to the conference, and they've certainly enlivened the conference. I can remember one occasion in particular where the merits of the so-called walking blood bank or emergency donor panel were being discussed, and some of our transfusion medicine colleagues were saying, well, it just can't be done practically. It takes too long. This is not something that NATO military should train because it's just never going to get used. And your experience in Iraq, and my own for that matter, belied that point. But we demonstrated in real time in a sort of mock-up session that unit of blood could be, in fact, collected for a casualty in under 10 minutes and transfused. And I think that really changed a lot of people's opinions. So bringing the doers in to talk to the policy people and the scientists, I think has been a really powerful aspect of THOR that has sort of fed this virtuous circle of implementation science, figuring out, how do we know when things like a bag of whole blood is full if you're collecting it in the field and you don't have a scale to measure it on, and finding more accurate ways to calculate that, coming up with abbreviated donor questionnaires that are practical for use in an emergency setting. I mean, these are all things that have come out of the THOR network, where that collaboration between doers and academics and policymakers has been really powerful. Maybe you can speak a little bit about one of those cases that we'd love to use as an example, our friends Heidi Dowdy and Pat Thompson.
Yes, every year at the meeting, I purposefully look and see who is having breakfast or lunch or dinner together. What new pairs of people has the network been able to put together? And every year I'm always surprised by the combinations or the pairings that occur. And it's really interesting. Pat Thompson, who's extremely experienced medic, I think he, a self-proclaimed knuckle-dragging, medic.
Former British Special Forces medic, yes.
Correct, yes. Has developed a, I think, very robust relationship with Heidi Dowdy, who led the UK's transfusion, blood program for many, many years, and is, very opposite to Pat, a very prim and proper, super sophisticated person. And to see the two of them together, it's the extreme odd couple. Right. But they have worked so well together, and that's what THOR does. THOR puts people together that wouldn't normally have gotten together because they all go to their own meetings. This multidisciplinary meeting that kind of handpicks, it is an invite-only meeting. We handpick people over the years to try to get different people to come every year and get those new pairings to facilitate and to accelerate change in this field. And I think that's been part of the special sauce of the meeting. And another aspect of the meeting that has also, I think, accelerated change is what we call the Table of Knowledge. The title of this podcast is the THOR Network Table of Knowledge. And very early on in the network, after the conference, right, many of us would go to the bar at nighttime to continue the conversation about what we learned throughout the day and share our experiences. And we all kind of gravitated to this one table in the back corner of the bar. And very quickly, we coined it the Table of Knowledge, because that's where I think a lot of the real meaningful discussions started to occur and would continue until 2 a.m. And many of the significant changes that have occurred out of the network have occurred at that Table of Knowledge. And one good example, and you were a big part of it, was the U.S. Army Ranger Low Tide Row program.
That's right.
They developed their program at the Table of Knowledge at 2 a.m, literally on the back of a napkin, when 8 or 10 of you all sat there and wrote it out. And we've had many other discussions at the Table of Knowledge about future research projects, training programs, right? One of our biggest successes is the online training program for pre-hospital whole blood collection and transfusions. This is a collection of 15 to 20 individual presentations, lectures with embedded video in them. And then we had over 5,000 medics view this training program. It's been so successful, the Ukrainian army reached out to us over a year ago, and the Ukrainians asked us if they could translate their course into Ukrainian, which they have. And now it's the main educational tool, training tool that they use for field whole blood transfusions. We've gotten a request from the Spanish to do the same. We have a lot of different tools within the network to be able to develop and disseminate knowledge. And I think we've come up with a new aspect of implementation science, right? Implementation science is basically using evidence-based medicine to change practice, but knowing what's going to resonate with that practitioner, what's going to facilitate change, and what's going to be a barrier to change. And as a hematologist, you may change practice differently than a surgeon or a transfusion medicine specialist or a medic. And classic implementation science learns what will make you change practice, right, versus somebody else. Right. Well, with what the THOR network has done, we've kind of short-circuited that entire approach, and we've brought everybody together and learned at the meeting, okay, well, what's going to make you change practice? And then for those who are not going to change practice, what is it that they need? And then we've done it kind of as a combination package, right? And that has accelerated change. So I feel like we're breaking new ground in this field of implementation science and using a network-based approach, multi-D approach to facilitate change. I mean, if you think about it, whole blood before 2010 was pretty much a dead issue. We were only focusing on ABO-specific whole blood back then. The world thought a cold-stored platelet within a cold-stored whole blood unit wasn't functional, and people were concerned about not being able to leukocyte reduce a whole blood product. We've addressed all of those barriers, and with the work that we've all done together with many others around the world, it is now becoming the standard care product. In the US, as of 2 years ago, there were 302 trauma programs using whole blood out of about 800 to 900 trauma centers or so. And there's 11 pediatric centers using it in civilian hospitals. Almost every NATO military program has transitioned to incorporating whole blood as part of its inventory too. And back in 2010, very, very few. I think the Brits, us, and maybe the Australians were using it, and really nobody else. So,
and not an inventory. I mean, I think the key point here is that we identified through that sort of implementation science approach what were the key drivers or barriers to implementing, for example, whole blood, but other products as well. And we went out and did the research. We got it funded. We did it, and things like the position papers, I think, have been helpful because basically the contents of those things have found themselves transported into clinical practice guidelines used by the U.S. and other NATO militaries, which have then, in turn, driven change in civilian organizations. So that virtuous circle of military to civilian sharing has been facilitated by the network. And so we've gotten whole blood back out there, which is widely acknowledged to be, at a minimum, a more convenient way and rapid way of providing full resuscitation to bleeding patients. And the clinical trials are now underway to determine whether it is actually going to have a mortality advantage over component therapy. But a lot of the observational data from registries and so forth certainly seem to suggest that it's at least as good, if not better. So that's really a major improvement in our ability to deliver care far forward that we and others have driven, but I think we've been uniquely positioned in the THOR network to help with the implementation of whole blood. And then you mentioned cold stored platelets as another example. Dried plasma has also been an area of great interest to the network. And I think
there's also been calcium, right?
Calcium early on.
As an adjunct to hemostasis as well too. Supporting
tranexamic acid.
The use of tranexamic acid early in resuscitation too. As well as other aspects of resuscitation, right? The airway management. Many of these patients classically would be getting intubated, and they're often historically, and maybe even still currently, getting intubated before being resuscitated, right? So, the whole concept of resuscitate before you intubate, right, has been a concept that THOR, with many others, has been pushing out to practitioners and explaining the pathophysiology right? The whole issue with being careful and restrictive with needle decompression due to the concern for tension pneumothorax,
Right.
right? It appears currently the current practice is over utilizing that approach, that procedure, and probably causing more harm than good.
Right.
So the THOR network has definitely gone outside the scope of just hemostatic resuscitation or the blood-based approach to hemorrhagic shock. It's the other, airway and other procedures that facilitate getting a casualty back to the hospital in the optimal physiology so that they have the best outcomes.
Right. I mean, generally speaking, the network addresses the problem of shock and major trauma resuscitation. And I think that we've really been able to drive in that direction. So,
I do, though. I also want to acknowledge the industry involvement in the meeting too. So I mentioned before, the main THOR meetings are invite only every year. We restrict the number to about 180 people because we found that's the number of people that facilitates, again, that close collaboration. You get to know somebody over 3 days. You're very comfortable going up, and speaking and debating some of the premier people in the world. And the example I always bring up is Gene Moore, right? Gene is one of the founding fathers of current trauma care, right, in the world. And if you get to swim with Gene in the morning, right, or have a beer with him at the table of knowledge, the next day you're comfortable saying, Gene, I'm not sure I agree with you, right? And it's that close connection. You can't have that close connection in a meeting of 500, 800 people. When the meeting gets to be that big, you lose that intimate quality of it, and you don't wind up talking to people outside your circle. At those big meetings, you stay with the people you know from home, and you don't reach out to other people. So we keep it limited for a reason, and that's been part of the special sauce, I think, too.
And I want to come back to the industry piece that you started to mention. I think that's super important because although, the academics can drive some of the research questions and some of the implementation work can be done by the medics and academics in collaboration and so forth, at the end of the day, we need new products.
Correct.
And having industry there has been absolutely vital. Why don't you?
And many of clearly, all of the industries have scientific leaders within them too. So they bring their own knowledge to the table as well too. And it allows us to interact with them to, I think, facilitate the appropriate development of certain products, and that they get feedback from us too. So it's a very symbiotic relationship. The industry is that
Doer feedback, right? From
right.
the medics, right?
Yes, of course. If for industries developing products that go into a medic, aid bag,
right,
they need to know what the medics need, what's going to facilitate implementation. So the industry partners have been a very big piece of the THOR puzzle too, and I don't think we would be as successful without their use as well. Now, I do want to say we've been focusing on Norway a lot. Since the meeting now has been in Norway since 2011, we didn't have 2 meetings because of COVID, but because to help with our outreach, we've now decided to move the meeting around a little bit more. So the main meeting is going to alternate between Norway one year and then probably within North America the next year. So this year is the first year we're having the main THOR meeting outside of Norway. And we're going to have it in Miami at the Fontainebleau Hotel, October 6th to 9th. So moving forward in the future, to improve our outreach, we will be moving the meeting between the Solstice Bomb and another location within the U.S., Canada, or perhaps even Mexico too.
Yeah, I mean, I think that this brings us back in a way to there are some challenges in running a network like this, right? Because at the beginning, the thought was U.S. and Europe, military, civilian, but clearly, as we've been asked to reach out to the world and bring THOR on the road and so forth, we have the good challenge of growth and building. I do want to mention one aspect that's, I think, really been critical and a nice piece of having the meeting in Norway every year is that we were able to, as part of the military contingent, invite a lot of members of critical subcommittees within NATO, such as the NATO Blood Panel, to come to the meeting, kind of like the medics have their pre-conference training course. There's usually a post-THOR, or there has been in many years, a post-THOR NATO Blood Panel meeting where policy discussions could occur, informed by the research presentations and implementation science and doer feedback and so forth that we got both at the pre-conference and at the main conference. I think as THOR expands around the world, the opportunities for growing that kind of policy influence are going to expand as well. Certainly we saw a little bit of that with THOR Down Under in Australia. Do you want to comment on that?
Yeah, no, the Thor Down Under #Thunder meeting in Australia last year was due to the fact that we were having many Australians come to the Thor meeting, but they were all very frustrated with the inability to implement whole blood in Australia. In Australia, whole blood is not allowed from a regulatory perspective, so they had that major hurdle. And one night, I'm pretty sure at the table of knowledge, we said, well, you know, we'll just bring THOR to you. We'll go to Australia, we'll have a 3-day meeting with the goal of just getting their regulatory agencies open to the idea of bringing low titer O whole blood on as an approved product. So in collaboration with the Australian Army and some of their leadership, we developed this 3-day meeting. And a day and a half into the meeting, the chief medical officer of Lifeblood, which controls the blood utilization and the regulatory aspects in Australia, came up to us and said, okay, we get it. We're going to start whole blood in Australia. And I thought they were joking with me. I thought, she was pulling my leg and just making a joke. And she was like, no, Phil, I'm serious. We get it. Based upon the data, your experience, and the logistics of it, we get it now. Thanks for coming here. And they are literally going to start in 2 large regions within Australia within the next 12 months, using whole blood pre-hospital and also rotating it in hospital too. So it's been very powerful and incredibly rewarding, right? To have, with a group of people, build this network and now just bring it around the world and facilitate change. We're having a meeting in Italy come October, and it's kind of the same story. Even before the meeting started, they've said to us, all right, we're going to plan to start using it after the meeting, but let's just have the meeting to kind of streamline the process. In Spain, we had our first meeting last year, and they have started in one hospital in Madrid to use whole blood.
And they're bringing this back.
Right, and we're having a second meeting this year. So there's been a lot of success stories from multiple implementation tools. But what we haven't brought up yet, and one of our sayings at THOR is that T-shirts save lives.
Right.
Right, and that whole process of making T-shirts at THOR started when one afternoon Gare called me and was complaining about the ubiquitous use of saline and crystalloids in pre-hospital in Norway. And interestingly, I was making pasta at the time. I was literally starting to boil water and was throwing salt into the pot to make it boil faster. And I said, yeah, man, it's simple. Blood is for bleeding. Salt water is just for cooking pasta. And he's like, Phil, that's awesome. We got to put that on a T-shirt. I was like, oh, stop, you're being silly. Why would you put that on a T-shirt? Though unbeknownst to me, he made THOR T-shirts with that saying on the back. And it kind of became a viral phenomenon, and people started using that phrase everywhere. I've had blood banks ask me for permission to use it as part of their advertisement for whole blood collections. And it's helped spread the message. Sometimes when you have a catchy saying like that, and you've had a few, others have had other catchy sayings.
Now, wait a second. My T-shirt in the THOR sales was running neck and neck with yours. Remember, blood bankers were telling us it was too hard to make whole blood.
Right.
And I said, collect whole blood, walk past the centrifuge, put the whole blood in the fridge, transfuse whole blood for bleeding.
Make blood banking simple.
They made simple, right. So
yes.
they're running neck and neck, let's face it.
Okay. But it has just helped spread the word. If you can have a catchy saying like that, it just helps, especially these days with social media and how the younger generation communicates. But what really brought it home.
Merch is important.
The swag always helps, no doubt. But what really brought it home and was really rewarding was when we, a THOR contingent, met with the IDF in early April to kind of review the program and then give some feedback. And if you remember, we were in the back of an APC, basically an up-armored, tank to provide medical care. And we're getting briefed by a young Israeli physician. She might have only been 24, 25, straight out of medical school, and running a medical unit. And I asked her, flippantly, just to make a joke, where in the APC did she keep the saline, to see what kind of response I would get. And she immediately says to me, without knowing I originated the phrase, she said, "Sir, we don't make pasta in this ABC. We use blood for bleeding." Right? So this is almost 10 years later.
Right.
Right? And I asked her, I said, "Where did you get that saying from?" She's like, "They teach it in our medical school as a way for us to kind of cement, or to imprint the concept." So, T-shirts do save lives. And it's been another fun part of the THOR network too, coming up with what T-shirt we can make next.
That's a wrap for this episode of the THOR Table of Knowledge podcast. A big thank you to our sponsor, Velico, for supporting the advancement of trauma care. Their frontline ODP spray-dried plasma system is paving the way for blood centers globally to produce potentially life-saving plasma for transfusions. Check out our website, www.thornetwork.com, for more podcasts, and join us next time as we continue to explore the cutting-edge science of trauma, hemostasis, and oxygenation. Until then, stay safe and stay informed.